Hi, I'm Dr. Robert Glatter, medical advisor from Medscape Emergency Medicine. Today we'll be discussing the care of athletes with COVID-19. Joining me today is a distinguished panel of sports medicine physicians from the Hospital for Special Surgery who provide care to professional athletes. Dr. John DiFiori is currently the Director of Sports Medicine for the NBA. Dr. James Kinderknecht is a team physician for the New York Giants, as well as the New York Mets. And Dr. Kathryn McElheny is a non-operative medical director and associate team physician for the New York Mets. Welcome to everyone. I want to talk about league protocols, NFL, MLB, and NBA, obviously. So, Kat, can you talk to me a little bit about the protocols in the MLB that you're using to test players?
Yeah, I think that probably our protocols will be adjusted prior to next year, and I know that probably the NFL will be the more updated version of these. But the way that we approached it for our season was if someone were to test positive on a routine serial monitoring type of test that we did with the saliva every other day, they would go home and to isolate and quarantine. They had to be completely asymptomatic for a full 72 hours before they were permitted back to the field. And they actually needed to have 2 negative PCR tests that were separated by 24 hours. That became somewhat problematic as the season went on because we learned that players can really continue to shed probably dead virus particles for quite a while. So we had other ways around that, other laboratory evidence that we would obtain, like cycle counts and antibody prevalence, et cetera, seroconversion to try to get players back when we felt that they truly weren't a risk to other people in the clubhouse. But typically, as the protocols at least started, you needed to at least have 2 negatives before you could return. And just because of the cardiac screening that we did, the earliest anyone could really come back in any real way was 14 days, because you did need to have at least 14 days from symptom resolution. So oftentimes it was longer than that, but typically it was 14-day minimum.
I'm a team physician with the Giants, so I'm kind of on the end game of it all. And so a lot of the protocols are all developed by the league, and then we're left with kind of complying with them and what have you. And we have the daily testing. So if somebody tests positive, there's a rerun of that positive. So there were some cases of false positives early on, and that was more on the lab error side of things. So I think first and foremost, we confirm they have it. And then at that point, it's really, then we start the contact tracing. We talk to them about their symptoms and what have you. Now, what it is then is they are protocoled out for 10 days. And you can free somebody from quarantine after 5 days and 2 negative tests. Although personally, we haven't pushed that so much because breaking quarantine is one thing, returning to play is another. So the league protocol as it relates to the concern with some of the cardiac involvement was hold people for 10 days. At the 10-day mark, do testing, and our testing has included an EKG, echo, and troponin. If those are negative, then they're cleared for a 3-day ramp up. So we do submaximal exercise, and we progress them over a 3-day period. So earliest is to return to play in 14 days. Now, everything gets pushed back if somebody is symptomatic. Now, fortunately, in the ones I've dealt with, we've had minimally to no symptomatic, short duration of symptoms. So, and we get everybody a pulse ox, they're quarantined, we have a hotel situation, all their food is delivered, and they're in constant contact with the medical personnel while they're quarantined. So typically we take them away from their home and quarantine them in these situations, or if they live alone, then we let them stay at home.
At the end of 14 days, they're PCR tested again, and that's the end of it?
Once they test positive, we never PCR test them again. 90 days. So they get a 90-day holiday because of all the issues with it's, and that's basically, in concordance with the CDC recommendations that, but we've seen people will test positive for out to 3 months easy.
Right.
We saw that early on, where we would have people that would come in and they've had antibodies for 2 months and they were still PCR positive. So we don't really use follow-up early on, when we're trying to clear people quarantine or confirm the diagnosis, we'll do multiple tests. But once we've made the diagnosis, we don't do any more PCRs for 90 days.
Okay, very good. John, if you want to go through your protocols too and just outline your approach, as James did.
So all positive tests must be confirmed. They're isolated until it's confirmed one way or the other. Then we actually initiate the contact tracing right away so that we're prepared to move forward if we need to with quarantining others. The CDC's criteria is applied in terms of when isolation is discontinued. We do test. We have a little bit different approach. We haven't implemented yet a test holiday following, a recovered case yet. We may. I think one of our concerns, at least in the early phases following recovery, is that because we are testing every day, we are in a zone which the CDC doesn't really account for. We may be detecting infections much earlier than is accounted for in the CDC's criteria. And so we do have some concern that there may be persistent infectious shedding after that 10 days because of that. So we have a little bit of a more cautious approach with that. So once they clear isolation, though, they're then going to undergo, like Dr. Kinderknecht was saying, a cardiac evaluation and then a gradual return to play. And that's kind of it in a nutshell. There's a lot of contact tracing, obviously, especially, we get concerned about household members in particular. But that's been our general approach.
Was there any thought to doing daily sort of rapid antigen viral testing, being that the more often you test, although they're less sensitive, that could be sort of a good bellwether if there was any degree of infectiousness among the players?
Yeah, it's a good question. And I don't know what the higher level conversations were surrounding that. I know that obviously we developed, a unique setup where we had our anti-doping lab that was transitioned into a COVID testing lab dedicated to us. And I think we achieved pretty impressive sensitivity and specificity with that test. So we were reliant upon that methodology overall. But in terms of the rapid antigen testing, most of the teams, all of the teams were actually offered the opportunity to purchase one of the rapid test machines to be able to have in-house. And I think all 30 clubs did end up purchasing one of the 3 options that Major League Baseball presented us with. And we didn't use it to make sure that we had daily testing, just because that would have been really difficult to do from a logistical perspective, because you have to do one sample at a time, et cetera. But we did, if there was ever a concern or a pending lab result, for instance, like if the lab hadn't come back for someone, not that they were positive or concerned that they would be positive, but we just didn't have a result for them. Or if there was someone who had recently gone to a doctor's appointment or something along those lines, we would supplement with rapid antigen testing with the Sophia.
Right. Going forward next season, is there any thought about using a bubble, just obviously with the success of the NBA and obviously with the issues of the beginning of the season and throughout the season with multiple teams?
Well, in the bubble, we did daily PCR testing, 12 to 14-hour turnaround time. And that worked very well for us. Obviously, the bubble is a different setting. Basketball is a different sport. We knew we had to test pretty much every day due to the frequency of competition. And plus the fact that, the players are exposed to each other on the court, close contact for extended periods of time, a little different than baseball, a little different than football and hockey. And so that's we knew that was going to be needed, is that daily testing. We also know, and probably apropos to your earlier discussion, is that we know that testing doesn't prevent infection. So we have a big emphasis on all of the personal protective measures, wearing face masks, face coverings, social distancing, washing hands, not eating around each other unless it's quite distant. All those things were very important. We had a very detailed infection protocol for all of the facilities. Because, as you probably know, the idea with the testing that you're asking about is really that it's designed to detect a case as early as possible. So you're trying to prevent sort of a campfire from becoming a forest fire.
Right.
That's really the goal of the testing protocol. Now, we're in a quite different situation as we begin our first preseason games tonight. So we're in a completely different scenario. We're not in a bubble. The pandemic is at its current height and hasn't reached its peak. So we did experiment with point of care PCR testing in the bubble. We're in close contact with our colleagues in the NFL and their experience with the same platform. And we're, because of the current situation, not being in a bubble, the prevalence of the virus in the communities now is so high, we're basically going to do twice daily testing regularly every day to try to narrow our window to no more than 12 hours where we're not knowing what the status is in terms of PCR. So that'll be our approach moving forward. Again, emphasizing that, the most likely way for anyone with an organization to become infected is going to be in the community. They're probably less likely to become infected within the training facilities or on the court. Certainly can happen, but the community introduction is really the main source of introduction that we feel we'll be trying to guard against.
But with your bubble during the season, you really didn't have the community to worry about. When you're saying the community as a whole, I mean, you controlled for that, and that's. Well, I think obviously raises the question: should all the leagues embrace the bubble? I mean, you guys had a great outcome. And
you have to remember. Yeah, I mean, you have to remember, different sport, and we only had to complete 20% of our season. So, normally we have a 82 game schedule. Trying to do an 82 game schedule in a bubble would be incredibly difficult from any number of standpoints, the least of which would be mental health. It's just incredibly difficult for players to be away from their families, coaches to be away from their families. It's a mental endurance test to be in a bubble for any time. Same thing with NHL. They were in a very similar circumstance. They just needed to complete the season. And so when you've got a full season in front of you, it's just would be extremely difficult to expect to be able to have that kind of success in a bubble over a long period of time. It's quite challenging from many aspects. We're entering into a 72 game season now. It's possible that we could revert to some sort of hub system or bubble system, depending upon how things go. Maybe even, down the road, we would consider that if we got to playoffs or something like that. But, there are other things that's going to happen along the way. The vaccine, as you know, is on its way, and we're not sure exactly how much that will impact us as we proceed, halfway through the season. So there's a lot of factors. I think one of the main things that we've learned is to collect data as we go forward and to review and analyze that data, adapt our protocols, and be nimble with that. And so same will hold true now, as we start using twice daily testing. What are we going to learn from that? As the pandemic continues to increase, are we going to be successful even with twice daily testing? Or are we going to have multiple introductions, teams needing to shut down, facilities needing to shut down, and then we're going to have to recalibrate. And, we're already considering what does that mean, for us. You've seen in the NFL where San Francisco had to move to Arizona because of local public health ordinances. And so we are always prioritizing player health and safety. That's paramount. That's first. The next thing is we do not want to detract resources from the public health effort. We won't do that. And the third is that we will always fall in line with whatever the public health guidance is. So everything follows from those three priorities, and then we go from there.
Right. Now, Ken, I want to bring you into the discussion. Obviously did not have a bubble in the MLB, but, this whole discussion we've just had about this raises the question of whether MLB would entertain in some form or a hub system or some other approach than what happened this season.
Yeah, I think similar to what Dr. DiFiori mentioned, I think it's going to be really tough in these sports that involve a full longer season. Our typical season is 162 games. So if you're looking at doing an 8-month season in a bubble, I think that would be a really big ask for players and families and the mental health component. And I think, from a baseball perspective, it's really logistically hard just because of the surface that we play on. If you look at basketball or hockey, for instance, you can reuse that court time and time again, and it's not going to cause an issue. If you play 3 games field, you're going to have to completely redo that field partway through the season. And that takes quite a bit of time. So I think it's a combination of getting player buy-in for, a very long season in a bubble. And I don't know that everyone would want that. And then I think the second piece of it is just the fielding perspective.
And in terms of player embracement of these mitigation measures, was there any resistance, not just among the Mets, but say among other teams that you had heard about? And what role, again, does leadership and buy-in play in this?
I think probably you had a mixed bag with every team. I mean, there were definitely certain people who believed in it and bought in more than others, that's for certain. But I think that in general, our team overall had a great attitude and they wanted to keep each other healthy. We had a code of conduct, and that was recommended by Major League Baseball, that each team develop their own code of conduct. And I liked that because I felt like the players were able to formulate that on their own. And it wasn't even something that they shared with the front office or shared with us as medical staff. But I think that in general, I think that everyone was a really good sport, and they had to be able to play the sport that they loved. And so I think that the leadership was absolutely crucial in inspiring that. Just in terms of some of the things that we learned, I mean, I think when you look at baseball, we obviously got off to a little bit of a rocky start there at the beginning part of our season. But I think that those two outbreaks with the Cardinals and the Marlins really showed us a few important factors. And I think that one thing that we learned that was somewhat more positive is the relative lack of evidence supporting on the field transmission. So I think while we did learn that there was can spread through indoor spaces and through our clubhouses and some of the shared facilities that our players were utilizing off the field, it seemed like on the field, we actually did a pretty good job of not spreading COVID-19. So, I think they looked at about 40 different game hours, 11 of those being on-field play, with the 5 games where there were unknowingly asymptomatic positive people.
Right.
And there was no transmission to other teams and no transmission to umpires. So I think that helped us reshape our protocols and really focus on containment and indoor prevention, social distancing, mask usage, as we've all talked about, but also just where to focus our efforts.
And finally, I want to talk about the delays in starting the seasons and whether the shortened time spent in training camps has had an impact on the players, and specifically if you're finding injuries to be more of an issue this year as a result of the delays. And James, I wanted to start with you.
Yeah, we obviously, this was a big concern, and it was a big concern with the players union, and appropriately so. So based off that, our training camp started a couple weeks late, and then we eliminated preseason games, and it was a very prescribed gradual ramp up, and it really was an attempt to recondition people, because the problem is nobody had resources through the summer and what have you. So there was a lot of off-season conditioning things that were just not performed. So it really was a slow ramp up to the start of the season. The injury surveillance in the NFL is quite high, and so we're going to have that data to answer it scientifically. Very anecdotally, on our team and just talking to other team physicians, we really didn't see that as a real problem where we had more soft tissue injuries, for example, hamstring injuries and the like. But I think it was partly because of, by design, there was a prescribed ramp up early on in terms of practice volume and intensity.
Got it. And John, if you want to weigh in on that too.
Yeah. So I think that was a concern, as Dr. Kinderknecht was alluding to, because it wasn't that we had, time off, players had time off because the league shut down. It was that they couldn't even train. Everything was locked down. Gyms, facilities were closed. And obviously we were concerned. We didn't want them trying to train in a public setting because of the risk of becoming infected. So it was really, we were trying to overcome detraining. And so it wasn't even like a normal preseason. So we tried to account for that as best we could by, from the time they first arrived at sort of the pre-resumption of season training in June, there was about 5 weeks before the first official game. So we tried to incorporate conditioning. With each team had their own, obviously, program for conditioning and getting players back into resilient shape. So again, similar to what Dr. Kinderknecht described, we haven't fully analyzed the data from the bubble in terms of injuries yet, but our impression was that the players did very well. As we move forward into this season, the training camp is more consistent with the usual preseason training camp in terms of time. It's too early to tell right now, obviously, for what we're going to see. But I think overall, the teams and the players did a fantastic job in getting ready for these very unusual circumstances. And we're very focused on their fitness. And I think the medical staffs for the teams did a great job in preparing them. So I think it went probably better than we had expected.
That's good to hear. And Kat, if you want to just finish this out and let us know.
I think that if you just look at the objective numbers, it does appear that we had more injuries during this shortened season. Now, if that actually correlates with a specific increase in injury rating, there's a lot of factors that contribute to that. So I wouldn't want to jump to that conclusion, but I think just anecdotally speaking and looking at some of the raw data, it seems that we potentially had more injuries. But I think there were some differences, in terms of our sport. So first of all, throwers need to throw. And during quarantine, if you don't have a throwing partner or someone to go out and do that with, it's really challenging. And we had, we received news that we had the green light to proceed with the regular season on June 23rd, and we reported to spring training on July 1. So we really had a pretty short window to prepare for spring training, and then a very abbreviated spring training of about 2 to 3 weeks when it's typically 4 to 6. So I think that, maybe those things contributed, but it's hard to interpret the data as well because we also we had a taxi squad right down the road, which was unique to this year. And the use of the IL was probably slightly different because of the shortened season and the utilization of that practice squad and the availability of those players. So I think it'll be really difficult to kind of interpret some of this data completely objectively. But I do think that it appears that we might have had somewhat of an increased injury incidence just anecdotally.
Right. That would be interesting to look at the data maybe at some point later on, whether it will be published or just, whether that's just an internal issue. I'd like to get everyone's thoughts about, or approaches rather, about how we're going to monitor patients in the postseason, not only for the effects of COVID, but also looking at their injuries and kind of making a very clear pattern or approach in terms of follow-up. Does each team or does each league have a protocol in place for this at this time?
I would say we haven't gotten as far as what are we going to do in terms of monitoring of our known COVID positive patients postseason. The protocol is in place. We follow these guys quite closely, and they get more physicals than any healthy person in any other setting. And so they get frequent labs. They all get an EKG a year. And so I think as I would anticipate this, we would be probably more symptom driven in terms of 3-4 months out. I don't think we're going to repeat the cardiac testing. I do think, it'll be probably become protocol that troponin may be part of our screening labs in this specific population that has been COVID positive. But I don't think it's going to change a lot in what we do in terms of other than monitoring symptoms and
right, just basic, approach in terms of like looking at symptoms more so than looking at, imaging tests in terms of like making decisions.
Yeah, I think it's not a whole lot different than what we'll be doing with the general population too. I think the big question is again, when we knew from early on that 20% of hospitalized patients had cardiac involvement, what we don't know, and we still don't know, is what percent of people that in a non-hospitalized population, either asymptomatic or minimally symptomatic, have cardiac involvement. I think some of the leagues, we can produce some of that data, and we're going to try to for everybody, is because we've had obviously a robust testing protocol for this special population of COVID positive patients that are typically these healthy, active, minimally symptomatic people. So I do think we're going to have data for the general public and all physicians to utilize. But right now, it's still so evolving that we don't know.
But when we saw the Big Ten deciding not to hold, the season in light of, this concern for myocarditis, that was a big scare, not only to the players and staff, but the public. Just thought, here these young athletes are out there and they could, have an arrhythmia and die. So I think that, data doesn't show that, and certainly going forward, we can make.
Yeah, I think that's why we all have to be careful with stating things that aren't proven, because I think we can create a hysteria, paranoia, and I think that was kind of pushed out there and then reeled back. But the problem is when those comments were reeled back, the paranoia and the hysteria had already been developed. So I think that's where everybody just needs to, be patient in terms of collecting solid data that we can then provide to providers to help make decisions.
Exactly. And Kat, we wanted to get your thoughts on that too.
Yeah, so I think in terms of our postseason monitoring, we are a pretty tight bunch. Everyone knows to reach out to our head athletic trainer, to myself personally, if they have any concerns or symptoms. And we've had a few situations that have arisen in the off season where you just talk them through the process remotely. Sometimes you help them arrange for testing if they have a concern, or testing for their family member. If for any reason someone were to test positive, we'd arrange for cardiac testing for them. And then you have our physical therapists and athletic trainers have a group of guys that they check in with regularly. So in terms of their return to play following any potential infection, that would be also closely monitored from a workload perspective. In terms of the cardiac piece, I think, it's challenging, and especially in terms of the interpretation piece, which is what Dr. Kinderknecht I know alluded to earlier. But a lot of the tools that we have to assess cardiac concerns are really reliant on a high pretest probability of that being true. And so the issue is that with some of our screening modalities in a relatively healthy and borderline asymptomatic population, our pretest probability is much lower. So I think it affects the quality and the interpretation of the tests that we have available. So it seems like there are emerging expert opinion consensus statements that are slightly different than some of the initial ones that came out. So I think it'll be interesting to see what the leagues adopt for next season. I'm sure that will be a topic of discussion, but in the off season, at least, we're continuing to recommend the same sort of protocol that we had during the season, which is the troponin EKG, which is low, has a low sensitivity for detecting myocarditis, and echo.
Right. And one other thing I want to talk about is the mental health effects of all this on the players. I mean, have any of you seen any kind of, sort of the inklings or beginnings of, some form of depression, anxiety?
Well, I think we tried to, from an organizational perspective, certainly be proactive. We have two people on staff. One is a psychologist and the other is an addiction health specialist. And so they work together to really try to, in a confidential way, be available for all of our players and staff. And I would really kind of echo the staff component too, because with reduced travel party size and trying to pull off this season, you're doing twice as much work with half the bodies. And so a lot of people were just really fatigued. And I think that was mental fatigue, it was physical fatigue, and I think it was players and staff alike. And by the end of the season, that was everyone's kind of comment was, man, we did it. I'm glad we made it through it. That was tough. It would be really tough to do this for 162 games.
Right.
So I think that the fatigue was a real element there as well.
Right. Do the players amongst, obviously the different leagues, NFL, MLB, NBA, do you feel like that there's some community now that everyone's gone through this and that they can all join in this together?
I'll start. I mean, I think that's actually one of the silver linings of all this is that, back early on in March when, we shut down the league, and even before that, to be quite frank, back in February, we were actively communicating with colleagues internationally in, sort of professional soccer and Australian football and rugby. And it did seem to really galvanize the medical community. And as we've moved forward in March and April, May, I can tell you that there's been regular communication with the major professional leagues, and the NCAA and other associations have their task force, and they've been communicating.
I think the biggest example how galvanized the league became, not our team, the whole league, is I think it wasn't until maybe 10 weeks into training camp combined with season before the NFL had their first case. So clearly we could create an ecosystem that really diminished risk. But, we've been talking about the community spread, and that's really where the risk is. If our players and our staff were doing less than smart things, exposing themselves to the crowd, not social distancing, not the mask and the whole bit, we would have had cases all over the place. So to me, what really was obvious is how much buy-in there was, that I do have to sacrifice some things outside this ecosystem to really make it work. I personally did not think that could happen. I really was pleasantly surprised, because you're talking staffs close to the players. Training camp, it's 90 players. We went to 80 players, so we're all carrying staffs, teams of 80 players. You then talk equipment, coaches, medical staff, that goes up to about 140 people easy. So any one of those 140 screwing up is going to bring down the house of cards. So I think that's, to me, the really evident answer, that people really did galvanize and work together. And I do think there was this collective, I got to do my part to make sure this works.
Yeah. And Kat, if you just want to finish out on your thoughts on the sense of community.
Yeah, no, I agree with everything that's been said so far. And I think the last piece I would add is, now with baseball being on the flip side of our season, I think that there was a kind of a camaraderie, or a sense of camaraderie from having survived it. I think that they all kind of went through uncharted waters together. We all navigated it together, both in the medical community, but also just the players and staff members. And that travel party of 60 guys will always have that experience together, and they battled through it together. And I think it brought them closer as teammates. And don't get me wrong, it was challenging and tiring at times for everyone involved, but I think that piece was also potentially a positive to come out of it.
I want to thank everyone for joining us today. It's been very informative, and I think our audience will truly appreciate this. Not only people who practice sports medicine, but all providers in general, because I think it's an important part of understanding how athletes are cared for and how we're approaching sports going forward during the pandemic.